From asthma to acne, from babies to bronchiolitis, June 2022 CFP Journal has got it all, and here we are at CFP Distilled. We're going to cover the most clinically relevant articles in this month's edition. I'm Dr. Simon Moore from the Review Course in Family Medicine. Stick around, we'll show you these articles, and we've got news about our summer course. See you there.
What goes better together for treating mild papulopustular acne than tea and biscuits? Well, it's combination treatments.
When considering the treatment for mild papulopustular acne, don't forget first line, topical retinoids and benzoyl peroxidase, second line, OCP and isotretinoin.
Beta-2 agonists in babies with bronchiolitis. If you are looking for a CCFP crash course on bronchiolitis, this article is a good one. Buckle up, let's dive in and take a look. So, turns out that giving a medicine that treats wheeze doesn't help the wheeze in bronchiolitis. So why is that? In asthma, beta-2 agonists work. They relax the smooth muscle constriction. So the smooth muscles that are tight in asthma, you give a hit of beta-2 agonist, salbutamol, and they inhale that and the muscles relax. But the mechanism of wheeze in bronchiolitis is completely different. It's a different mechanism. It's caused by respiratory epithelial cell sloughing. It's caused by inflammation, mucus in the airways. It has nothing to do with smooth muscle constriction. And for that reason, the beta-2 agonists don't work. Could you list on an exam some reasons why we don't want to give them? You can get side effects, tachycardia, irritability, flushing, tremors, and it's also been shown to reduce oxygen saturations in some patients as a side effect. So make sure you're considering giving the treatments that are effective for bronchiolitis. There's lots that work really well and lots that don't, and you should be able to list these on an exam. So what are the ABCs of treatments that do not work for bronchiolitis? A is for antibiotics. They don't work. B, beta-2 agonists. C, corticosteroids, and a bonus one, E, epinephrine or racemic epinephrine, also shown to be ineffective for babies with bronchiolitis. So if you've got an exam question and there's a child with bronchiolitis, they come into your clinic, how do we manage them? We're going to use supportive treatment. We're going to treat them with hydration. We're going to manage their secretions with suction if needed. And we're also going to make sure that we are supporting their oxygen saturations. Supplemental oxygen if they need it, if they're getting hypoxic. So that's management of bronchiolitis in a nutshell. Fantastic article. Take a look in this month's CFP Journal.
How important is pulmonary function testing for the diagnosis and management of asthma and COPD? Turns out it's really important, but we're not doing it enough. 30-40%, sometimes people don't have their official PFTs even a year after diagnosis. So what happens to these people? Well, it turns out we're over-diagnosing COPD and asthma, and then we're underestimating the severity of COPD. So you need to get those PFTs. Guidelines recommend everyone over the age of 6 should be getting their PFTs. So don't forget this really important investigation.
So 7 years ago, Dr. Paul Dillon and I started the Review Course in Family Medicine. There was nothing like it on the market to help people like you prepare for the CCFP exam. And so that's why every spring and summer, we go across Canada to help people prepare. This summer's offerings, we have listened to you, we've listened to what you want. People have asked us, we want an option for more streaming, for longer streaming options. So we've got a virtual course and you can choose the length of streaming if you want to come and see us in person at the Review Course in Family Medicine, Toronto, summer 2022. We will be there. We are bringing our high energy faculty. We've got our high yield tips, tricks, and exam preparation strategies. We'll cover them all. I hope to see you there in Toronto, summer 2022 at the Review Course in Family Medicine.
Binge eating disorder was added to DSM-5 in 2013. So what is binge eating disorder? Well, you have a feeling that you're losing control and eating an abnormally large amount of food over the course of 1 to 2 hours. In terms of male to females, think about that 1 to 2 hours, but flip it. It's more common in males in a 2-to-1 ratio. It puts people at higher risk for hypertension, diabetes, and a number of other conditions. So what can you do for these patients? Well, they're pumping away. Guided self-help, pharmacotherapy in a stepwise way. That's what you need to remember for binge eating disorder.
There's a case report in this month's CFP Journal about the NRP guidelines failing this group of clinicians. They were stuck, they were stranded, they didn't know what to do. They got to the point in the algorithm and then they got the treatment. The coolest conclusion, the treatment for this child's case was ice cold. So what happened? A child was born unresponsive and they went through the algorithm. If you want to memorize NRP as easy as possible, this is your 2 mnemonics you need to know. Number 1 is tone, tears, term. You walk into the room, you check the baby's tone, you find out, are they crying? And you find out what is their term significance? Are they preterm, term, or post dates? Then for each branch point in the algorithm, the other mnemonic you need to remember over and over in your mind, breathing, beating, blue. is that what's going on? Great pediatrician in Nanaimo, BC taught me this trick, because if there's a problem with one of those 3 areas, you've got to adjust something. If they're not breathing adequately, if their heart isn't beating adequately, or if they're cyanotic, if they're blue. So then you adjust things, and they did that for this baby. They adjusted positioning, they stimulated, they gave adequate ventilation and oxygenation, but there was still poor perfusion. How can you measure poor perfusion? You should be able to write this down on an exam. Well, they found that the pulse was weak and thready, and they also found that the cap refill was prolonged. It was more than 4 seconds. So they did an ECG, got a hemoglobin, tried to find out what is going on with this baby, because the NRP algorithm doesn't really help much for a child who is hypoxic, who's got a weak and thready pulse, but their heart is fast. There's lots of tips on bradycardia, but not for tachycardia. So the ECG showed a heart rate of 278 beats per minute. This child was diagnosed with supraventricular tachycardia. They called the neonatologist. They said, we're getting ready to cardiovert the child, either with adenosine, you should know the dose, 0.1 milligram per kilogram, or with an electrical cardioversion. Again, another dose you should know, so 0.5 to 1 joule per kilogram. And as they're trying to set up the equipment, the neonatologist says, why not just use the diving reflex? Get a bag of ice, put on the child's face, allow them to still breathe while you're doing this, and it worked. Boom, the heart rate plummeted, the child was saved. NRP may not help you with tachycardia, so consider broader differential diagnosis, call for help if you need it, and be able to manage and recognize supraventricular tachycardia in a neonate.
Don't forget to sign up for our Toronto course in the fall, and all of our dates for 2023 are coming up soon.